Welcome. You know, in healthcare, there are some skills that are just fundamental. They're the bedrock of good patient care. And today, we're tackling one of the big ones, nasogastric tube management. So, let's dive right into this essential clinician's guide.
So here's how we're going to break it all down. First, we'll cover the basics, the what and the why. Then, the super important safety checks. After that, we'll get into the procedure itself, then how to confirm we got it right. And finally, we'll wrap up with long-term care. It's the whole shebang, from start to finish. Okay, let's start with a really common clinical problem. Imagine your patient can't swallow safely after a stroke, or maybe they have a bowel obstruction and you need to empty their stomach. What do you do? Well, in so many of these cases, the answer is the NG tube.
All right, first things first. Before we can really get good at using this tool, we've got to understand exactly what it is, and maybe more importantly, why we even use it in the first place.
So, what is it? Put simply, a nasogastric or NG tube is just a soft, flexible tube that goes through the nose, down the throat, and lands right in the stomach. It's a direct line in. Oh, and you might hear it called a Ryle's tube, especially in certain parts of the world. It's the exact same thing.
And the versatility of this little tube is just amazing. I mean, we use it to give nutrition, to relieve pressure from a blocked-up gut, to wash out the stomach in cases of poisoning, to give meds. You can even use it to get samples for testing. It's a real workhorse.
Okay, moving on. Knowing when to use an NG tube is one thing. But, and this is a big but, knowing when not to use one, that's probably the most important safety check there is.
And hey, lean in for this next part. I'm serious. Whether you're studying for boards or you've been practicing for years, this is absolutely critical information. And, you guessed it, it shows up on exams all the time. So, we split these no-goes into two groups. Absolute means stop, full stop, do not pass go. Think major facial trauma or a basilar skull fracture. Then you have relative, which is more like a yellow light. It means you need to be extremely careful. Things like bleeding disorders or a really bad gag reflex fall into this category.
So here it is, the big takeaway. If you remember one thing from this section, make it this. If your patient has a significant head or facial injury, placing an NG tube is incredibly risky. Why? Because you could accidentally guide that tube right through a fracture and into the brain. It's a nightmare scenario we have to avoid at all costs.
Phew! Okay, now that we've covered those crucial safety rules, let's roll up our sleeves and get into the practical side of things, how we actually get the tube in safely and efficiently.
You know, not all tubes are the same. You've got to pick the right tool for the job. The classic Ryle's tube is your go-to for feeding and getting stuff out. But for decompression, you really want a Salem sump. It has this extra little blue tube that lets air in so it doesn't get stuck to the stomach wall. And for long-term feeding, the Dobhoff is often the winner. It's way softer and more comfortable for the patient.
Now, patient positioning is everything. Seriously, it can make or break the procedure. For insertion, you want them sitting straight up at 90 degrees. That's high Fowler's position. It just makes gravity your best friend. But for feeding, you'll lower them a bit to a 30 to 45 degree angle to help prevent anything from coming back up.
So, how far in do you go? Great question. There's a super simple way to measure this called the NEX method. It's an easy-to-remember acronym. You measure from the tip of the nose to the earlobe and then down to the xiphoid process. Just mark that length on the tube, and that's your target. Easy, right?
And here's the play-by-play for the actual insertion. First, you explain everything to the patient and get your gear ready. Lube up the tip of that tube. Then, you gently insert it, aiming down and back, not up. And here's the magic trick. Have the patient take sips of water and swallow. As they swallow, the esophagus opens up, and it just helps guide that tube right where it needs to go. Once you hit your mark, you just cape it securely in place.
All right, the tube is in, but don't celebrate just yet, because what comes next is, without a doubt, the single most important step of this entire procedure. You have to prove it's in the right spot.
So, what's the one way, the absolute, undeniable method to prove that the tip of that tube is safely in the stomach and not sitting in a lung?
An X-ray. That's it. It is the undisputed gold standard. An X-ray gives you a picture, black and white proof that removes every single shred of doubt. Before you put anything down that tube for the first time, this is how you get that 100% certainty.
But let's be realistic. You can't run down for an X-ray every single time you need to check the tube. So what's the next best thing? What's the safest and most reliable check you can do right there at the patient's bedside? That's where a little bit of science comes in handy. It's pH testing. You just pull back a little fluid with a syringe and test it on a pH strip. Stomach acid is, well, very acidic. So if you get a reading of 5.5 or less, you can be very confident you're in the right place. And you can also just look at the fluid. If it's a grassy green or yellowish color, that's another good sign.
And here we are in our final section. The tube is in, it's confirmed, but our work is far from over. The day-to-day management is what ensures our patients stay safe and gets the benefit of the therapy.
Now, when it comes to feeding, there are basically two main ways to do it. You've got bolus feeding, which is kind of like a regular meal. You give a larger amount with a syringe over about 10 or 15 minutes. Then there's continuous feeding, which is a slow, steady drip that runs for hours on a pump. You see this a lot more in the ICU for patients who can't tolerate the bigger volumes.
And these are your daily must-dos. You have to verify that placement every single time before you use the tube. Always keep the head of the bed up. Flush the tube before and after meds to keep it from clogging. Keep a close eye on your patient for any signs of trouble. And please don't forget mouth care. It makes a world of difference for their comfort.
And finally, we've got to be on the lookout for complications. The one we all fear most is aspiration pneumonia. It's incredibly serious, and it's exactly why our technique has to be perfect. But you also need to watch for other things, like the tube getting dislodged, the patient feeling sick, or even just a little pressure sore on the nose from the tape. Knowing the risks is the first step to preventing them.
So there you have it. We've gone through the what, the why, and the how of managing an NG tube. And you know, the procedure itself is a science, but the real art is applying all these technical skills with genuine care. So that leaves me with one final thought for you. Once you've mastered the technique, how do you master the compassion and communication that turns a simple procedure into truly healing care?